And if you look over there, post-ACTH, what have you done to your cortisol levels? It's high to begin with, and what have you done to it? Stimulated even higher, haven't you? Okay, and again, it's just showing you the results of the low-dose dex, and that's supposed to cause negative feedback, but if it's a tumor up there, could it care less about negative feedback? No, so you're not going to reduce a normal pituitary. If you give low-dose dex in a dog, your levels will decrease below 1.25 as far as your cortisol levels are concerned. You do that and you don't see that, then that tells you it's not responding. And what's one of the problems with neoplasms? Do they respond to normal regulation? No. Okay, now to differentiate again between pituitary and adrenal dependent, you use the high dose dex in all your species. In animals that have an ACTH secreting neoplasm that's responsive to negative feedback, what is a high dose dexamethasone going to do? Will it suppress some of it? Yeah, and you usually drop to about 50% or less of the baseline cortisol levels. In other words, if the baseline cortisol was 20, you may drop down to 10, 8, something like that. Okay. But what if it's an ACTH secreting neoplasm up in the pituitary that doesn't care less about negative feedback? You going to see anything? No. What if it's a primary problem? Is it going to care less about the ACTH to begin with? No. So you do your high dose dex. If that cortisol level drops 50% or greater, you got your diagnosis. It's a pituitary neoplasm that's responsive to negative feedback. If it doesn't, then it can either be one that's non-responsive or it can be primary. What are you going to do to differentiate between those two? Well, I'm talking about ClinPath tests and stuff, endocrine tests. If it's a tumor up here, what's causing the hyperadrenal corticism? Too much what? So what about measuring endogenous ACTH? You measure endogenous ACTH, it's sky high. Where does that tell you your problem is? It's up here. What if it's low? That tells you it's primary, because primary, you're suppressing ACTH secretion, right? Everybody follow that? Please make sure you all understand that, because how you interpret these tests, these cases and stuff are based upon that, okay? And these little diagrams here just explaining the high-dose dexamethasone suppression test and what it's supposed to do. Okay, with both pituitary dependent, remember ADH in this case is adrenal dependent, okay, not the hormone, all right? And did we see much of a change with the A and B there? Because what could care less if it's adrenal dependent? Could care less about, it's not being regulated, period, is it? By ACTH. Whereas if you look at it on the pituitary dependent, what happened to our cortisol level? It's suppressed, so that tells us it's a responsive tumor. But again, some of those tumors aren't going to respond. And that's basically where the endogenous ACTH comes in. It's useful in all species. It's worked out better as far as they had more statistical data as far as the canine. It does work in all species. But it's a little more expensive. Okay, so it's a little more. So what you're hoping is that it's got a normal, dexamethasone suppression tumor up here that responds, but that doesn't always happen, okay? So, drug therapy. How are you going to treat pituitary-dependent hyperadrenal corticism? Your mitotane right there. And again, the mitotane destroys cells in the zona fasciculata, but usually, notice it says usually, but what's your case going to be? I'm going to read the book, and it's going to take out the glomerulus also, isn't it? It reduces those cells in the fasciculata. So what's that going to do to cortisol production? Decrease it. Now, you're trying to get a dosage, again, where you don't see clinical signs of having no glucocorticoids. So that takes time to do that, okay? And that's one of the main ways we do in the dog. Also one of the main ways we do in the cat. Lots of times with cat with adrenal problems, you just take out the adrenal glands, period, and just supplement with fourfold. Okay. For example, up at the top is there's a mixed breed 18-month-old dog that had a pituitary-dependent hyperadrenal corticism. B is that same dog after, dog left the normal littermate. You can see the difference between it and its normal littermate up there? And we look down here at C, that's the same dog, 5 months following initiation of therapy with mitotane. Look a little bit better? Alright, well, let's look at the next one there. That D there is a 6-month-old German Shepherd that had pituitary-dependent hypergonadism. And for some unknown reason, that dog went for 4 years without any therapy. What does it look like now? Nice, beautiful specimen there, right? If you're a pathologist. Now, F is that same dog as in D and E 4 months after initiating therapy. It look a lot better? Look a lot happier? Yeah, now we haven't completely solved his problems, but it definitely doesn't look as bad as it did in D there, does it? Or E there, does it? Okay. Again, it's a 10-year-old crossbreed dog had pituitary-dependent hypergonadism. The first panel is before treatment with mitotane. B, first one up there on the right, is the same dog after commencing treatment. And the bottom one is the same dog 6 months later. So is your treatment working? Yeah, so you go, but again, you can't judge immediately. You have to see, you can carry this animal out. So what does that mean? You're just going to tell the owner to bring the dog back next year? Or are you going to bring it in for regular sessions, examinations and stuff? Another one right here, a papillon up there.